Thanks Alzheimer Europe for hosting this INTERDEM symposium. My talk closely relates to the COVID-19 crisis. Social distancing started as a strategy to combat the acute threat of the virus, but gradually turned into a long-term strategy. The sprint became a marathon, and this requires adaptation. Social distancing contrasts the strategy, the social health promotion of INTERDEM, but social health offers also possibilities to reduce the risks of social distancing. And I'm going to tell you how and why. First, I'm going to share my screen with you. And here we are, INTERDEM, and much of what I'm going to tell you is about work that has been done by INTERDEM members. The topic is social distancing, protection, and risk. And it's especially a call to balance between risk of the virus and risk of loneliness. Why is this so important? Social distancing deprives older persons from valuable assets of social health, such as participation in social activities and the response of the social environment by actual interactions. So people are really deprived from social interaction and they don't like it and try everything to connect. Like here in the Netherlands, in the first lockdown, people tried to visit a family member on the third floor of a nursing home. Why is this so important? Well, because of the impact of social isolation. We know from previous studies on previous lockdowns that social isolation has a detrimental effect on cognitive functioning, on physical health, on psychological health, and on social health. And this is mainly done by loneliness. Social health, many of you might be familiar with it, but I also want to give you a view on social health, a perspective on what is healthy, what is social health. That's one's ability to form satisfying interpersonal relationships with others and to adapt comfortably to different social situations. It's about the competencies of the individual and the competencies of the social environment and its interrelation. We described social health in our manifesto, among other ways to guide future research. Social health is a key point at this moment in INTERDEM. But we are especially interested in the relation between social health and cognitive functioning and dementia. And therefore, we need to collaborate with other colleagues, with biomedical colleagues. And we are very lucky to get a grant to do so and to study the interplay between social health and biological and psychological factors on the trajectory from cognitive healthy through MCI to dementia. And here we are, our European group and our Indonesian partners, and in both you see the INTERDEM partners in this very important and challenging study. And this study is guided by a hypothesis on the relationship between social health and cognition. And we consider social health to be the driver to use cognitive reserve. I will come back to cognitive reserve. But how is it the driver? It's by active use and facilitation of the social environment and of the social capacities an individual has. And about cognitive reserve, that's the hope in the story. It's the ability to actively withstand neuropathology by using compensatory and cognitive approaches. So having some bypasses, making some bypasses. Well, in order to study social health, we need social health markers, and we try to find social health markers, and so far I can give some examples. For instance, the contact frequency, friendship networks, neighborhood networks are really important, and then the perception of relationships, whether you perceive it as support or whether it is annoying. So we are not naive. It's not only one side. It's not only beneficial. It can be a real struggle, and we as human beings know how that is. Social engagement is a key point in social health. There are several social health studies in epidemiology, meaning that there are some social health aspects measured, but there are already very important findings that gives hope for this hypothesis. And these findings are that social capital and neighborhood networks have a beneficial a beneficial effect on social functioning, on cognitive functioning, and so has social activities and a satisfying social life. But it is another important finding that lack of social interaction is associated with incident dementia. So there are many ongoing studies at the moment. That's one of the good things of the crisis. There are good things in the crisis. But we also ask people to write blogs for our website. And I'm really touched by the experience of a person with dementia. He said, I was told that I can't leave my home for anything and must stay indoors for 12 weeks. And then I started to panic because my routine had just been thrown straight out of the window, and I started to think, will I be able to cope living on my own? Well, shielding in this way is hard. It's hard for everyone, but it's harder for a person who can't understand why and what is going on. And it has been found, not surprisingly, that people living with dementia experience faster deterioration. And this was related, in this case, to not accessing social support services anymore. And this also stresses the importance of social health services. And then there are blogs about family carers. There are tips for family carers, especially on how to make decisions. And there are tips to keep families connected to nursing homes, for instance, by a special nurse liaison, and by emphasizing the power of feedback from families, from shared care between the family and carers in the nursing home. And then there are blogs about reducing the risk to mental health. And one is very important, I think, and that's taking a little risk to try to prevent a bigger risk that strict lockdown presents to mental health. So if you trust people and you know how they are living, contact them instead of going for a full lockdown for yourself. And then care workers have an incredibly hard task at the moment, and they need support themselves. And for instance, 3/4 at least needed a listening ear. So we can do a lot, and a lot of things to improve social health and to maintain social health. And we can use the usual canals like multidisciplinary collaboration and psychological first aid. It's important to pay attention to behavioral management and to palliative, to make plans together with the person with dementia. So all these things should continue to go on. And there is a special tip: when you have to work with a mask, play a bit with it. Remove the mask at a distance to show who you are. That's important. And because we are all in the same boat, I have some recommendations for all of us. For instance, make as many chats during the day as possible. Try to meet people in any way, even by Zoom or walking in the street. It has been found to have a beneficial effect on longevity. And if you are feeling alone, take responsibility for your loneliness. Don't wait until someone comes and saves you. And visit people with dementia as much as possible. And then there's one I really want to share with you. Replacing touching by verbal expression of affection. Now we can't touch. We have to show it in another way. Tell a person that he or she met us. Well, I really hope you now know how important social health is, and you don't take it for granted anymore. And I really wish that you be careful about your social life and you cherish your bubble. Thank you for your attention. I want to emphasize that you can ask questions during the presentation itself, and you can ask questions by using the chat function. Are there already questions coming in, Rabih?
I can only add that thank you, Myrra, for your presentation and for the pointing out the concept of social health, which now is more very important when we are having the pandemic times. We have in Poland the different results relating to face mask covering. I will talk a little bit in my presentation, but yes, it was something I was interesting when you talk about this idea that we should have distance, but to show people who we are. In Poland, the reaction on face masks is very positive because people then are thinking that we are responsible and we are taking care of the others. But your point of view in Netherlands, I think, could be maybe a little bit different. So it was something interesting for me. Thank you for this.
Oh, well, thank you for giving me the opportunity to address this point. This was from a patient on the intensive care, and that patient saw only masks. And then in that situation, he suggested, if you come into the room or leave the room at a safe distance, remove the mask so that I can know that there is a real person behind. It's not for the usual use of mask. Then you can better keep the mask on. Yeah, okay. Is there any?
So there was a question from Debbie.
Yeah.
Yes, I was wondering whether you have experience with a buddy system among care providers or among people with dementia. Do you have any heard about experiences with such a system?
The buddy system? I don't know.
Mm-hmm.
What do you mean by it?
Now, I mean, for instance, that one care professional in a nursing home has one a colleague who she can turn to in case of burdened feelings or feeling sad, or that is something that has been implemented in nursing homes in the last years. And I was wondering whether you have heard about such a system in home care or among people with dementia themselves, maybe.
Oh, a body. Yeah. Now I know body. What you mean by body? No, I don't have research information on this. I only have information that 3/4 of carers really need someone who is listening to them. They need this support themselves.
Okay.
And thank you for this question. And there is room for more questions at the end of the session. But for now, I would like to move forward, and we are going to travel. We are going to travel from Poland to the Netherlands to Italy on experiences with COVID-19 in these countries. And I first want to give the floor to Dorota Szcześniak from Poland, and she will give a presentation on mental and social health consequences during the pandemic in Poland. The floor is yours, Dorota.
Ladies and gentlemen, thank you for the opportunity to participate in this session devoted to the concept of social health. Nowadays, this concept is more relevant than ever. Because of the ongoing pandemic, we face everyday limitations in interpersonal contacts and social life. The freedom in relationships take different shapes. We all know that social activities are limited by the necessity to maintain social isolation and distance, which aims at reducing the risk of further coronavirus transmission. However, we also are aware that the reality in which we live and to which we have to adapt will have its consequences. I would like to take the opportunity to share with you the conclusions drawn from the online survey conducted in the general population in Poland during the first wave of the coronavirus that took place in spring 2020. Over 2,000 people took part in the study, aged 18 to 82 years old. The study sample was dominated by women and people living in large cities. Over 66% had no chronic disease, and over 84% had no history of psychiatric treatment. Nevertheless, the results obtained during the first wave of COVID cases were alarming. More than half of the respondents showed clinically relevant psychopathological symptoms, such as depression, somatic symptoms, social dysfunctions, and anxiety and insomnia, as it was measured by the GHQ questionnaire. Moreover, most of the respondents, as many as 79%, felt loneliness due to the restrictions and due to recommendations related to maintain physical social distance. The social distance negative consequences, such as loneliness, were perceived significantly more often by women. One of the key responses to the changes and threats of the pandemic was fear. However, fear was not only related to personal health. Most people were concerned about the health of their loved ones, which is primarily an expression of the essence of the relationship and the fear of losing it. Moreover, almost half of the respondents believed that the fear for physical health had a negative effect on their mental health. Additional consequences of the pandemic were visible in such results as 63% of people declared worsening of mental health due to media reports. Most of our respondents were frustrated and angry. Some have experienced destructive coping responses, such as increased alcohol or nicotine intake and increased use of psychiatric drugs. One of the most visible changes in our social reality was the introduction of face masks. As we could imagine, various people's reactions on this specific restriction could be expected. According to our study in Poland, during the first wave of COVID, the restriction was rather positive. Our studies emphasized the overall decrease in psychopathological symptoms after the obligation to wear face coverings in a public space. These results can be considered from different perspectives. On one hand, such behavior may reinforce people's sense of personal control, and while being in a certain stage of the adaptation, mitigate helplessness and moderate anxiety, which includes strengthening individual coping resources. On the other hand, the face mask is seen as a symbol of social cohesion in the global response to the pandemic. It shifts the focus from self to the other and improves the collective responsibility. And what about the quarantine? This is actually another phenomenon influencing social health and social isolation. According to Chinese nationwide study, almost 35% of quarantined individuals experienced psychological distress. And how it was in our country, in Poland? During the first wave of the virus, among our respondents, only a small group of people experienced quarantine or had limitations regulated by law in interpersonal contacts because their relatives or friends were quarantined. Our results indicated that individuals on quarantine had significantly higher total GHQ score and the scores of specific GHQ subscales, such as somatic symptoms and anxiety and insomnia. Moreover, they had higher frequency of clinically relevant psychopathological symptoms according to GHQ, and had significantly higher scores in IESR arousal domain questionnaire. Furthermore, the quarantined individuals were significantly more likely to use self-destruction as a coping strategy. Among this group, positive correlations were found between psychopathological symptoms and maladaptive coping strategies such as denial, discharging, substance use, behavioral disengagement, as well as self-blame. On the other hand, the quarantined individuals were significantly less likely to use adaptive coping strategies such as active coping, planning, acceptance, positive reframing, or even sense of humor. Due to the small percentage of elderly people, also those living with dementia among the respondents from the online survey, additional data were collected based on the individual interviews in the qualitative research approach. Semi-structured telephone interviews were conducted between 16th of June and 10th of August 2020 among informal care partners and people living with dementia. The preliminary conclusions that I will present are based on 21 interviews collected at this time. However, I must mention that we are currently continuing our research. Unfortunately, care partners' observations on family members living with dementia are alarming. They are pointing out significant increase of depressive symptoms among people living with dementia, a huge problem with social relations and social isolation of people living with dementia. And what should be taken into account, this decrease in life activity associated with social isolation of people living with dementia may have a real impact on their long-term functioning and the illness progression in accordance with the concept of social health. This actually care partners are highlighting in their observation. They noticed irritability and aggressive behaviors, rapid cognitive deterioration, as well as the decline in daily independence. The most frequently experienced emotions in this group of respondents, people living with dementia, but also the care partners, was loneliness due to isolation, anxiety, fear for the health of their relatives, frustration, and fear for the future. Unfortunately, for those living with dementia, the restrictions related to the pandemic and the necessary physical isolation can have far-reaching negative consequences in terms of limiting the continuation of tailored care, support, and treatment. In many countries, such as Poland, the elderly, as well as people living with dementia and their carers, have already been confronted with limitation of access to healthcare and social support before pandemic. At present, however, the situation is even more difficult. Where are we now? The data shows that in Poland, for sure in the second wave of the spread of the virus, where the number of new daily cases have never been so high. And as long as young people have adapted to the new conditions, working and studying online, meeting with friends online, social isolation is still the recommendation and the big problem for the at-risk groups such as people over 65. How we are to maintain social health these days? How we can support the social health of people living with dementia? We are aware that social health is one of key elements that has an impact on the cognitive reserve. We all know that maintaining an efficient network of contacts, participation in meetings, and group activities can be a source of better cognitive performance in the elderly and an important factor in slowing down the illness progression for people living with dementia. Promoting the concept of social health is no longer the only challenge we will have. It is rather a challenge related to the search for solutions in a reality which is limited by restriction, in a reality which the order of the world, as we know, changed dramatically. I think we all will have a lot of work to do. Thank you for your attention.
Thank you, Dorota, for your excellent presentation and giving insight in the Polish situation. And well, you did a very good job at jumping into new research immediately. And it is good that you can compare these data also with the Chinese colleagues. Are there questions at the moment, Rabih?
No question, just as I say, from Susan, there is a great presentation for Dorota. Congratulations with Dorota now. I don't know if someone else have some question for Dorota. You can write it on the chat for the question.
Yeah. And can the presenters be unmuted?
Yes, we are.
Yeah. Yes, but I don't see Debbie. Well, there is one intriguing finding. Well, it's not so much information on it. It's just a case storytelling about a rapid cognitive deterioration. Do you have figures about it?
No, this is not based on figures. It's only based on interviews with care partners and informal carers. And this is only now the results which are based on their observation after a couple of months of their family members' isolation. And they are noticed this based on the daily routines and also the behavior of the family members. So here we are having only the information based on qualitative data, not quantitative.
Yes, but there is a lot of narrative information on this very important topic, and it would be great, maybe some of the attendees do have information on it, if we really can present some information on it, because this is a frightening result.
Yes.
Yeah, and especially when the isolation will have a longer duration, it will be worse. Are there...
Yes, I can add that now in Poland we are in a big crisis a second time, because we are having the second wave and it's much bigger than before. And even though we opened day centers, meeting centers before, now they are second times closed. So, and this is what's happened last week and this week, and we will have more and more restrictions. And for Poland, it will be for sure bigger consequences than from the spring, because in spring we were quite lucky with the cases, I think, and now it's something which is which we are having not under our control anymore. So it will be a huge problem.
Yeah.
Sorry,
Can I ask a question?
Okay.
Yes, please go ahead.
Yes. I was very intrigued, Dorota, by your finding that there was less adaptive coping in people who were quarantined. And
yes.
Do you have any thoughts on why that would be the case?
When we are thinking about it and we are talking about it, I think that in the spring it was not so many people who were under quarantine, but people were frightened by what will be going on, if they will have some problematic symptoms and so on. Somehow people, when I isolated, couldn't use the resources they have, and they are starting to use maladaptive resources. So we don't know why it is, because we have no data on this, but we can imagine that together with the fear and with no information about the virus that time, it was something that make people cope worse. They can, yes, something like this.
Thank you. Rabih, last question for this moment.
No, I am just curious to hear, because you had interviews, if there are some information about a positive reaction, not only because you mentioned only symptoms, anxiety, and so on. If you collect some idea on there are positive reaction to this.
I think that from care partners, there were more negative reactions and emotional reactions. However, there were a couple of, I would say, neutral reactions taken from people living with dementia when they were talking to us that actually they should adapt to the situation, and it's something we should cope and not to be frightened of. But I think that it was from those people who somehow also were before isolated, so there was no so much change for them. And those who also have the personality resources to adapt to the real situation. Also, we were having the feedback from those with worse cognitive functioning, that sometimes they were not aware about the situation, and they were not, aware about what is actually a coronavirus and so on. So for them, there was no topic.
Thank you.
Thank you. Rabih, are there questions coming in?
No question, just an appreciation for Debbie from Vanya.
Then I can ask my question. Well, this is a great result that at the end it's no longer allowed to do a total isolation. And Rabih, I think in Italy it's still the case, isn't it?
Yeah. They go back to the close again long-term care for visits. Last week they do it.
Yeah. And in the Netherlands, Debbie, do you have any information on, you had new guidelines? Are they still in place? Are they still implemented?
Yes, I think so. There's a new version. I don't know exactly when it became when it started, but people are trying to uphold the guidelines, but also adapting it to the local context as much as possible. And they are really trying at the moment. I saw a question coming below the screen on the current situation in the care homes, because we have really a second wave going on at the moment, and we can really see that all homes are really trying not to close down entirely, although some say, well, we need to close this location because there's a breakout, but more commonly locations close one ward or one unit and hope to contain the infections like that.
So
sorry.
There is two questions on the chat, Debbie. I don't know if you can read them. They are mainly about how the second one, do you think that the guidelines will be the same in the second wave, especially the ban? And the first one is, what's the current situation in the care home in the Netherlands following the presented guideline and the second coronavirus wave? Are the national guidelines tailored locally following the infection rates? So it seems similar as question.
Yeah, I said something about that already, and I think that there were two things. The fact that people weren't allowed to go outside was something that, looking back, was decided that we should not do that again. That was really too harsh. And too upsetting for people. So this is a very topic now in locations to be able to let people go outside, and also not to lock down an entire organization, or if possible not an entire location, but to limit it to units or perhaps parts of units.
Can I have just a quick question? Because you talk about supervision of visits, so what do you mean that during the visit between parents, one from the staff is present at the visit? Is this what you mean by supervision?
Yes, that's intriguing, right? It was the case that in some nursing homes that there was someone from the nursing staff checking in after a quarter of an hour or 30 minutes, for instance, to see how everything went. So there was discussion about that, whether that was appropriate to do that, but some homes decided on doing that because they had many, indications that people didn't follow the protocol, especially the 5 feet distance that needed to be upheld.
Thank you.
Yeah, well, in the Netherlands, this is a national problem. Following rules is not something
we are good at.
No, and especially not such rules. So there is room for more questions at the end, but now I want to continue the session, and I want to give the floor to Rabih Chattat, and he is as long as it's not started, he is a board member of INTERDEM, and he's a professor at the University of Bologna, the oldest university in the world. And he is going to talk about community service for people with dementia and their caregivers. We deal well during COVID-19, but it's time to restart face-to-face meeting.
Good morning for all. First of all, I would thank Alzheimer Europe for organizing this conference and give all of us the opportunity to share our work during the COVID-19 period in this session focused on social health. The focus of my presentation will be on community services for people with dementia and their caregivers. On the 24th of February, all community services had been closed just 2 weeks before the start of the lockdown in all the country. During the lockdown period and also the COVID-19 period, attention had been focused on nursing home related to the risk for elderly people, consequences of being affected by COVID-19. But regarding people living at home, people with dementia and caregiver living at home, they had been closed, but no action had been undertaken to support, to develop some type of support for this. In the area of Rimini, Emilia-Romagna region, in the north of Italy, the regional dementia plan some years ago set up the so-called open access space, such as the meeting center, meeting place, and Alzheimer cafe, where people with dementia and caregivers and their caregiver are involved and can receive information, advice, and take part in activities such as occupational activities or music, dance movement, or cognitive stimulation, so a wide range of opportunity and possibility. After the closure of all of these activities, we start thinking about how to be in touch and how to support those who are at home. So the first step of this project had been to assess needs of people with dementia and caregivers, and also the impact of the lockdown on their well-being, on their social life. The participants of the open access services have been interviewed by phone call by the staff, asking them about needs, impact, but also asking them about resources or tools that can be used in order to plan activities during this period. The main results coming up from this first step had been a sense of loneliness, isolation, and also people with dementia mainly outline the fear for them of being forgotten by others. So and also the feeling of emptiness and inactivity. So being closed at home without contact with others for them had been difficult to manage. So feeling of sadness, uncertainty about the future, how things will go, how will be the future for them had been also difficult to think about. And also both people with dementia and their caregivers outline that there is an absence of support and contacts with others and someone from where to receive advice or support. About resource and tools, most of them say that smartphones or tablet can be a useful way to be in touch and to receive and to interact with others. So based on this first results, we developed the so-called Reconnecting Pupil project, where we try to put together the previous staff of the open services, the open access services, with participants at this services, both people with dementia and caregivers, trying to reproduce the activities. So we already know about pupils, so we try to suggests activities which are related to them, using phone and video call, mainly video call, because they appreciate the possibility to see each other, to see faces, and also we develop activities can be individual or group session. It depends on type of activity, but also on preference of the person, with dementia or their caregivers. And to support this activity, we develop a kind of tutorials for example, for cognitive stimulation or for occupational activities, music or dance movement, which can be sent at home. So within the meetings, people can also continue their activities. So the project had been to contact people 2 times a week for 1 or 2 hours. It depends on type of activity, if it is individual or both caregiver and person with dementia, or it is a group activity. It depends on the type of activity it is developed. In this project, we involve 346 people, 90 people with dementia, and 256 caregivers who participate previously at the open access services. 11 staff members have been involved in being in touch and interacting with pupils, such as psychologists, dance movement therapists, music therapists, occupational therapists. We start with the project on the 15th of March, and we report about until the 30th of June. How we collect data methods. So we collect data using interview with caregiver, with people with dementia, about the impact, about their experience during these activities and these contacts. We also collect WhatsApp feedback from people with dementia, and mainly also from caregivers. So they share with us their ideas and their feeling and experience about these activities. And we also ask caregivers and also staff to have a kind of narrative report where they can describe in really detail their experience, giving us information about the impact, about of the activities they take part with. So we come to the results. For people with dementia, first of all, they enjoy to be in touch again with the staff. So they really appreciate the staff, remember them, try to be in touch with them, ask to be in touch with them. They also enjoy activities online. They take part actively, they are well concentrated, and they ask to, and they also had been really participant in the activities. They express a sense of vitality. You know, it is difficult to describe, but we can say that they feel they are living the situation, not only waiting that the situation will pass on. And also is a possibility to be reconnected to pupils that they already know during the open access services. For example, other friends or other participants and to know about them and how they are dealing with this situation. Even if at the end, all of them report that they are waiting to reopen. For someone, online activity had been useful because they feel a less social control and less stigma, so they become more active. For caregivers, the issues that come out, that receiving support, receiving advice during this period had been important for them, so they learn how to deal. They learn also more about their parenting care, because living with him more time than previously, let them know more about him and interact better with him, but also for them being in touch with staff and other caregivers had been an important point. So not feeling alone, not feeling isolated, even if they also say that something is better than nothing, so it is a good alternative, but they are also waiting to reopen and restart and to meet face-to-face. Also for the staff, running again activities had been important for them, and they also recognize some capacities of people with dementia unknown previously during the open services activities. So they outline that they allow them the online activity to explore new possibility to maintain continuity of care with people with dementia and their caregivers. So as overall, we can say that online activity during the COVID period had been appreciated, even if it is seen as a transition period, waiting to reopen again, asking for face-to-face meetings, and they want to be more close to us, the people, to see them. For this, during the July and August, when lockdown measures had been less severe, so they organized and they planned for outdoor meeting in order maybe keeping safe, but more close and more in touch. So I can conclude that the support and involvement during lockdown period had been important. Social interaction support vitality of people, because feeling alone, feeling isolated had been very, very difficult for both people with dementia and their caregivers to manage and deal with, even if online activity are almost seen as a waiting period. We don't have any other opportunity, so we appreciate the online activity. The lesson we can say we learn from this, that online and face-to-face activity can be integrated. It's not needed to keep them separated, even if all are waiting to restart. They are looking and waiting to restart. So I would thank you for your attention, and also let me thank also all the people with dementia, caregiver and staff who take part at this project and contribute actively. Thank you.
Thank you very much, Rabih, for this very informative and very interesting presentation. And it really gives some insights on which we were really curious to know about. And well, it's so precious that this kind of research has been done for all three of you, has been done nearly on the spot. Are there questions? Rabih, you can look at the chat.
I am looking at the chat, sorry, because now I am a speaker, so I have to move to the other role. It's not easy.
The different roles, yes.
Yeah. So there is a question from Maria Aurora. You say, what do you mean by your last sentence? Will relative be legally allowed or not, considering the manifesto you spoke about earlier? I am not sure to understand well. I am talking about community services, or so caregivers, relatives are living together with people with dementia. So they are in home, they are closed in home, or at least they can move, but services are not available. So services are still closed, so they have to manage the situation, but they are living together. So I don't know if I understand well your question.
Rabih, there is another question for you.
Yeah. Do you know if the professional were employed? Yeah, this had been an interesting issue. So the time that usually professionals use to do face-to-face activity, they use it to do online activity. So for professional, it had been the same job, and it had been so they don't, how you say, they don't had an impact in terms of work for them from the COVID period. So it had beneficial for them also, not only for pupils.
Dorota, you had a question?
No, I only wanted to point it out that there is a question on chat, but Rabih just answered. So yeah.
Can you take the next question on chat?
There is no more.
No, there is no more. Oh, then.
So sorry, because we have one question for you, Myrra, from the starting, and we missed it at the starting, and I think we should reply to it, even if maybe if there are other questions for it is from Santiago Brandi. What type of technology do you believe is missing currently to combat the isolation produced by the social distancing? So it come up from your presentation.
Yes. Well, I think we have a lot of technology in place, and this might be good for the moment. And a good message from your presentation, Rabih, was that people they might struggle with it, but if you support them, they can use also the new technologies. But there is one thing which is of which all the people are familiar with, and that's the simple telephone. And why not using this extensively? And well, it's very nice to have a video calling, and it adds to something. But still, I don't think there is technology missing. But we can more use technology, and especially the good old telephone is working very well. And I think we should use that very, very often. And that keeps people connected in a way they are familiar with and they are not frightened with. Because a day like today, it's, well, all of us has been nervous at a certain moment by the use of this technology. And the telephone, that's familiar, it's easy, and it always works. So that's my answer to it. Use the existing technology as much as possible. It's nearly 6 o'clock. I think it might be a great idea to pre-record presentations with regard to time restrictions, because we all stick to the time. And well, we promise to have time for more questions, but well, time is gone by answering questions in between. And I don't want to let you go before thanking all the presenters by their excellence, for the excellent presentations. And as a curious person, my curiosity has really been satisfied by your presentations. I myself enjoyed it very much, and I want to thank all those who attended the meeting that were at a certain approximately 50 persons. And I hope you enjoyed it and you learned something from it. And in many of the presentation, well, the problems were indicated very clearly, but there was also hope, and there were a lot of possibilities on how to improve and sustain social health. And I hope we can use that in daily practice. Thank you for your attention.
Thank you as well, Myrra.
Thank you. Thank you, Myrra. Bye.